So good evening. We'll start with a few clinical scenarios. So the first is a case of a 25-year-old athlete who presents with syncope during a marathon race. He is otherwise asymptomatic. Then we have a 30-year-old lady who presents for a regular checkup, and she is very afraid because of history of sudden cardiac death in her family members. She, however, does not have any cardiac symptoms. And there's a 35-year-old male who presents for a regular health screening, and he's told to have bizarre ECG changes, and hence he comes to you. So this brings us to this elusive topic that we called as hypertrophic cardiomyopathies. So as we can see, there are myriad presentations in which this HOCM can present. So what exactly is HOCM? So basically, it's the left ventricular hypertrophy which develops in the absence of hemodynamic factors. As we all know, left ventricular hypertrophy is mainly the physiological remodeling of the heart, which occurs secondary to an increased afterload. This occurs in conditions such as systemic hypertension or aortic stenosis or coarctation of aorta. So what exactly is this hypertrophic obstructive cardiomyopathy? So this is a condition in which the left ventricle hypertrophies in the absence of any of these factors. So you see that a patient is having hypertrophy on the echo, and he does not have hypertension or aortic stenosis. That's when you suspect this. So the first time that it was discovered in the 1800s, they named it idiopathic hypertrophic subaortic stenosis because it was not at the level of the aortic valve, but it was just below that. So we come to the genetics of HOCM. So 50% of the cases are mainly due to the mutations in the sarcomere, which is part of the myocardium. So the most common gene that is involved is the myosin heavy chain, which is the MYH7 as well as the MYHBCP3. So it's an autosomal dominant condition with incomplete penetrance, in the sense that not all the members are affected and not all the members present in the same way. So what is the pathophysiology of this entire condition that we call HOCM? So the basic fundamental behind it is that the heart is pumping against a high afterload. So this is going to cause a lot of hypertrophy in the left ventricle. So what happens is the pressure in the left ventricle goes up. At the same time, this is going to cause backward pressure, so increased pressures in the left atrium. So over time, what happens is that the left atrium as well begins to dilate. So as the left atrium dilates, what happens is that it goes into a condition which is called as atrial fibrillation. As the atrium thins out, it's more prone to a condition such as atrial fibrillation. Further on, as the pressures continue to increase, these left atrial pressures are transmitted to the pulmonary pressures, and the pulmonary capillary wedge pressure increases, and overall the patient has chances of going into pulmonary edema. So this happens in the later stages. So the first symptoms that the patient can present as a result of this is exertional syncope as well as exertional angina. As the myocardium continues to hypertrophy, there can also be some amount of subendocardial ischemia, which can cause some amount of anginal symptoms. At the same time, what happens is the pressure, as the pressure in the left ventricle increases, there is also going to be increased flow velocity, as in the cardiac output is going to increase in view of the increased afterload. So what happens is that the mitral valve gets sucked towards the left ventricle. So towards the left ventricle. So what happens is this mitral valve, as it gets stuck more so in systole due to the pressure changes, this causes a dynamic obstruction. So the obstruction that is found in HOCM is not a static one, rather a dynamic obstruction. So these are the main pathophysiological changes that occur in HOCM. So to revise what all we have learned till now, so the most common mode of inheritance in HOCM, it is autosomal dominant. The most common gene that is involved is the myosin heavy chain, which is MYH7. The most common site, as we had learned, the first name that was given to HOCM is idiopathic subaortic stenosis. So subaortic is the most common site. And the most common region of the heart which is involved in this hypertrophy is the interventricular septum. So the posterior wall is less commonly involved. So what are the symptoms that they come with? The most common symptom which is seen in 90% of the patients is that they remain asymptomatic. So they would just present to you like the patient who presented on a regular health screening and had bizarre ECG changes. The others would be symptoms of heart failure. As the left atrial pressure increases and the pulmonary capillary wedge pressure increases, they have tendencies of going into pulmonary hypertension as well as symptoms suggestive of orthopnea when they go into heart failure. Atrial fibrillation, in view of dilatation of the left atrium, they can have palpitations. And in view of the subendocardial ischemia, they can also have nocturnal angina. And most importantly, the most common cause of sudden cardiac deaths is HOCM. So we come to the signs that can be seen. Pulse. So to start off with the pulse, what we see is what is called as the pulsus bispherians. Pulsus bispherians basically refers to two peaks which occur in systole. So the first peak is mainly because the heart is pumping against a heavy afterload. So it pumps and that comes as a first peak. The second peak is because of the systolic anterior movement of the mitral leaflet, which causes a dynamic obstruction. So this causes a second peak. So these two peaks in systole is what we call as the pulsus bispherians. The apical impulse can be double or triple apical impulse. Then we come to the S1. The first heart sound is usually normal. Unless there is a concomitant mitral regurgitation, then the first heart sound becomes soft. The second heart sound, as we all know, the second heart sound has an aortic as well as a pulmonary component. So what happens is that the pressure gradient across the aortic valve is much greater than that of the pulmonary valve. So the A2 generally will occur late. So what happens to the split? As we know, it is A2 followed by P2. So since the A2 is occurring late, the split will narrow, or we can also have a reverse split. S3 will be seen if the patient is in heart failure. The most pathognomic heart sound that you can find in case of HOCM is the S4, which is basically occurring due to the atria contracting against high LV pressures. So S4 will be definitely found. What about the murmur of HOCM? So this murmur of HOCM is something enigmatic that has been asked multiple times prior. So this is a pan-systolic murmur which is heard at the apex, predominantly because whenever there is a systolic anterior movement of the mitral leaflet, they are prone to mitral regurgitation. So there will be a pan-systolic murmur which is heard at the apex, and there is an ejection systolic murmur which is heard in the parasternal area, mainly because of the pressure gradient across the aortic valves. Come to dynamic auscultation. So this is a question that has been asked multiple times. It seems to be very daunting initially. However, when we understand the basic concept behind it, it becomes much easier. So the first mantra that we have to learn is all murmurs decrease with the Valsalva maneuver except HOCM and MVP murmurs. Okay. So we come to what are all the dynamic factors that can influence the murmur. We come to ionotropy. So ionotropy basically means that there is an increased heart rate and the preload as well increases. So what happens is that whenever there is a decrease in the preload, such as dehydration, or you give a person who is in heart failure, you give them diuretics, or somebody with HOCM who's come with a fever and who's highly dehydrated, what happens to the amount of blood in the heart? So it's going to decrease. So the LV cavity size decreases, which basically means that the obstruction is going to increase, so the murmur increases. So any decrease in preload with dehydration, or such as even during the Valsalva maneuver strain phase, whenever the LV cavity size decreases, the obstruction increases and the murmur increases. Then we come to decrease in the afterload, such as when we administer amyl nitrate. So what happens when we decrease the afterload? So the pressure gradient is going to decrease. That means that the LV cavity is less under strain. So whenever there is a decrease in the afterload, the murmur is going to decrease. Then we come to increase in the afterload whenever we do a hand grip. So whenever we do a hand grip, what happens is that there is the pressure gradient across the LV cavity is going to decrease, such as in squatting, hand grip, or with phenylephrine, and hence the murmur intensity is going to decrease. So if we just know how each of these maneuvers is going to decrease or increase the afterload as well as the preload, we can identify how the murmur changes. So we come to the diagnosis. This is the ECG showing the characteristic HOCM ECG. So the first classical sign that is seen is that there will be features of LVH, which includes tall QRS complexes with STT changes in the lateral leads as well as the anterior leads. And the most pathognomic sign that is seen is dagger-like Q waves, which are seen in 1 AVL and V5 and V6. So this is showing the dagger-like Q waves. So whenever you see a clinical condition or a clinical clue where there is history of syncope with this kind of dagger-like Q waves, the first thing that you have to think of is this HOCM. So this is the echo, which is showing the systolic anterior movement of the mitral leaflet. So during the systole, the anterior mitral leaflet moves towards the LVOT and causes the dynamic obstruction. Now we come to the treatment. So how do we treat an HOCM patient? It depends on whether he is symptomatic or asymptomatic. So in symptomatic HOCM, the first step would always be administration of a beta blocker, because the beta blocker is going to decrease the inotropy and it's going to help in the symptoms that are arising as a result of this obstruction. However, beta blockers are not going to have any change in the myocardium, as in they are not going to reverse the obstruction, they are only going to offer symptomatic treatment. If there is a contraindication to beta blockers, as in if there is an airway obstruction or history of COPD or asthma, or if they are intolerant to beta blockers, then the other option that we have is the calcium channel blockers. If there is no improvement in the symptoms, that is when we do the echo and measure the LVOT gradient, it continues to be high, if more than 30, more than 50 millimeters of mercury, then the third drug that we use is diazopropamide. If a patient continues to be symptomatic despite all of these medical management, then we'll have to go to surgical management, including alcohol ablation of the septum or certain other surgical methods. Now, these are what are the basic things that you have to know in case of a HOCM. But beyond the basics, we should also have certain extra edge points. So, what is this apical HOCM? So, they might give you an echo photo which is showing this, which is suggestive of a spade of heart appearance that we can see. Here you can see that there is some amount of hypertrophy only at the apex. So, this spade of heart appearance is what is called as the apical HCM, which is also known as the Yamaguchi syndrome. Now, when we came to the medical management of HOCM, I mentioned that the beta blockers, calcium channel blockers, all of it do not have any definitive role in reversing the hypertrophy. However, there is a novel allosteric reversible myosin ATPase inhibitor, which is a new drug which has been developed, which is known as mavacamten. So, this could be a potential question that they could ask in your exam, which is which of the following has a definitive role in the activation or the modification of the myocardium in HOCM. So, now let us look at an MCQ which was asked in Neet 2024. So, all of the following increase the murmur of HOCM except. So, the options given to you are Valsalva maneuver, amyl nitrate, diuretics and hand grip. So, now that we have understood how the afterload and preload works, so the answer would be hand grip, because hand grip increases the afterload. So, whenever the afterload is increased, the pressure also decreases and hence the murmur decreases. So, all the other options would increase the murmur except hand grip. Thank you.